time, we're going to wrap up what I call the little short chapters of this of the book, where they deal with individual topics in single chapters, but the chapters are very short and pretty straightforward. So we're going to do immobility and stress today, and then we'll do pain and environment the next time. And then I sent out a change to our lecture schedule because I realized that pharmacology talk is real short. So I figure we can start in on the blood disorders and buy ourselves a little more time that way. All right. So immobility. And while these topics are short, I do think they are kind of interesting, and they have clinical relevance because they're often things that we encounter so rarely that we don't think very much about. All right. So immobility, obviously lack of movement. You can have part of the body that's immobile. You can have the whole body that's immobile. The immobile part or patient can be in a variety of different positions. And the causes can be, many. It might be iatrogenic. We put somebody's arm or leg in a cast, and of course that's going to affect their mobility. Neurologic disruption can result in immobility, a coma, for example. Muscular, a patient with muscle weakness, either from neurologic cause or from direct cause, like Duchenne's muscular dystrophy, for example. That can lead to immobility. And certain metabolic causes. Now, your metabolic situation has to get pretty screwed up to be immobile from it. But things like profound acidosis can do this, hyper or hypocalcemia. So just some words. Hemiplegia is paralysis of the left or the right side, so it's one half of the body. These are pretty uncommon. They can result from massive stroke on one side or the other. Rare spinal cord injuries can do this, where the whole spinal cord wasn't damaged, but just half of it was. Paraplegia is much more common. That's paralysis of the lower half of the body. That's your classic spinal cord injury, where either the spinal cord was crushed, severed, whatever, in a trauma, and that results in no innervation to the lower limbs. Quadriplegia is also kind of a classic spinal cord injury, this time at the neck. So one of the reasons we take such careful care of people's cervical vertebrae in a trauma is we're trying to avoid quadriplegia, which, for obvious reasons is a major life changer. So that's all four limbs, as well as, to some extent, the trunk. So altered states of consciousness, like you can see in CNS injury, the whole body can become immobilized because the patient is too confused to make purposeful actions. So they end up immobile. And the effects are going to depend upon the extent. In some ways, a whole body immobility is more of a problem than a single part, like an arm in a cast, for example. So the degree, and then as well as the duration. The longer, the worse. The longer the immobility, the more problems you're going to have as a result of it. So there are a number of treatments for immobility that are sort of general. They apply to all of the different things that we're going to talk about today. One is physiotherapy. This is passive. Oftentimes physiotherapy is used to describe active exercise too. But this is where somebody basically moves the body parts for you. So if you have a patient who has a temporary paralysis, let's say, from a spinal cord injury, a common thing is you continue to move those parts of the body that can still move. The reason for that is to hold on to the mobility at those joints. Anytime a body part is immobile, it becomes more and more rigid and less flexible. So physiotherapy helps to maintain range of motion. We have to pay particular attention to body position in the immobile person. A person in a coma, they can't move when their skin becomes uncomfortable at a pinch spot, let's say. So, we have to do careful inspections of the patient's skin as well as their body position, how weight is distributed, all those things to prevent some of the things that we're going to talk about, like decubitus ulcers. Respiratory therapy. We very much evolved to be moving around things. We sleep at night, but even while we're asleep at night, we move, we change positions, and we turn. And it turns out that both the respiratory system and the GI system are kind of dependent upon us being up and moving around. You know, that's how the weight is supposed to be distributed. What we find in a couple of areas is that immobility all by itself results in things like respiratory depression or an increased risk of pneumonia. So we'll talk more about that later. And then prone position is about the worst position you can be immobile in. Now, this isn't going to come up very often. You know, you're talking about maybe a patient with major back surgery that has to be on their belly. And I had an error in my slides. I had lying face up, so fix that if you haven't already on the one on Angel. But because we really didn't evolve to be lying on our bellies, you know, the internal organs are kind of pushed up and into under the diaphragm, so it gets in the way of respiration. The intestines and urinary tract were not designed to work under constant pressure like that, you know, from the outside. So we try to keep people out of this position as much as possible, but in the rare patient, it's kind of unavoidable. All right, so first up, musculoskeletal effects. The body very much follows the rule of if you don't use it, you lose it. Whether it's muscle or bone, anytime you stop using a set of muscles or even an individual muscle, it very rapidly loses strength, endurance, and mass. So this is not a thing that takes place over years. It's a thing that can take place over weeks. So anybody who's had a cast for any length of time, you know, when they take the cast off, you know, your arm or leg looks all spindly and skinny, and that's this muscle atrophy. No muscle contraction, and the muscles start to shrink. Now, the number of cells stays the same, so it's not that you're losing muscle cells, it's just the muscle cells are becoming skinnier and skinnier because they have less myofibrils in it, less muscle fibers. In addition, we have to be careful to prevent contractures. So a contracture is an abnormal positioning of the joint. So, for example, the flexor muscles are usually stronger than the extensor muscles. So, in an immobilized patient, they'll have a tendency to creep into flexion as their neutral point. You see this most profoundly in people who are bound to a wheelchair, as we'll see in a minute. The ankle position gets distorted because of this called a contracture. The muscles are pulling, and as they become more fibrotic instead of flexible, they get sort of tough, and they pull the joints into bad positions. This is another reason we do physiotherapy, moving those joints around, is to try to keep the neutral position, in other words, the at-rest position of the joint as normal as possible. In addition, tendons and ligaments, which hold muscle to bone and bone to bone, become less elastic and start to shorten when they're inactive. So there again, if you've ever been in a cast, you may have found that arm kind of stiff and hard to move at first. And it's because those connections have to be stretched periodically to stay stretchy. You know, otherwise they just start to cinch up and they don't want to stretch anymore. All right. Eventually, prolonged, and this is going to be months, not weeks, but prolonged muscle inactivity. At some point, the body kind of gives up on that muscle entirely, and it starts replacing muscle tissue with fibrous tissue instead. Now, the problem with fibrous tissue is it is not as elastic as muscle, so it's much harder to stretch. And all fibrous tissue in the body has a tendency to contract all the time, so it gets shorter and shorter. This, too, can result in contractures as that fibrous tissue pulls that joint out of a normal neutral position into something else. In addition, less muscle tissue means more weakness. Wasting is just the skinnying or the thinning of muscle. Decreased flexibility, like we talked about. And eventually, it's irrecoverable loss. If a muscle is immobile for long enough, it won't come back, even with treatment, although that takes a long time for that to occur. No muscle activity means no skeletal muscle pump, and that's as our muscles contract around our vessels, it helps to push blood back up towards the heart. So if you're not moving around, you don't have that, so you have a tendency to have venous pooling, you know, blood pools in the dependent portions or the lowest portions of the body. The same thing that happens to muscle happens to bone. Bone is very much alive. You know, we often think of it as kind of like dead scaffolding that, you know, holds us up. But the reality is it's living tissue, and it's making bone and dissolving bone all the time. So the bone tries to be only as strong as it needs to be, and it determines how strong it needs to be by looking at the forces that are imparted to it. So if, like in the leg bones, for example, if a person becomes non-weight bearing for a prolonged time, those bones don't get any stress, and they start to get less and less calcium in them. They start to become osteoporotic, as the body is trying to not have bone be where it's not being used. So bone strength deteriorates. As these things happen, as muscle disappears or as bone disappears, when muscle disappears, nitrogen is released because there's huge amounts of protein in muscle, and protein has a nitrogen component. And then when bone is dissolved, calcium is released. So you can see derangements in nitrogen, protein, and calcium metabolism as these effects take hold. All right. So here's an example of a contracture. This looks like it's probably in a fairly young kid. But you can see that the ankle has been pulled in towards inversion, and that the ankle is flexed. And there again, it's because, particularly in the legs, the flexors are the ones in the back that make up the big part of the thigh, and they're only resisted in the front by this thin little muscle called the tibialis anterior. So the ankle has a tendency to flex down, to plantar flex, or pointy foot, point down. So we try to prevent this with physiotherapy, moving that joint, weight bearing where we can. In the wheelchair-bound person, contractures are inevitable. There's nothing you can do about it. Eventually they're going to occur. And when that's done, often they're surgically corrected just for the patient's comfort, and so that they can do things more easily, like put socks on and put pants on and things like that. Hard to do when your foot is stuck in flexion. So the surgery for that is they actually cut the Achilles tendon so that then that ankle can move more easily because it's not being pulled on all the time. So that's musculoskeletal. Skin also very much alive, and it doesn't take very much time to damage skin, even not irreparably, but to cause a major skin breakdown. And skin is most sensitive to circulation impairment. So any place where the weight of the body, and I know many of you have heard this in other classes and it's review, but it's worth reviewing. Anytime the weight of the body is sitting on skin, the circulation there is going to be compromised. And that's because our blood pressure, while it's plenty adequate to make blood flow around the body, it isn't enough to lift the weight of the body up off of an artery. So what happens is blood just doesn't get to those compressed parts because the pressure isn't enough to lift the body in, particularly in overweight people. So anytime the weight is on a bony prominence, in other words, there's very little tissue between skin and bone, that's a high-risk area. But anywhere where there's a circulation problem. So the particularly vulnerable spots, the ischial tuberosities, these are the parts of the pelvic bones that we sit on. You know, they make the butt bone, so to speak. And there isn't very much tissue between that and the skin, and it holds the whole weight of the body. The sacrum, the greater trochanter of the femur would come up if you have somebody in a lateral position. You know, they're on their side. That weight's going to be pushing on that greater trochanter, which sits at the lateral side of the femur. And then heels and elbows, because again, there's not very much skin there to cushion, and heels and elbows get forgotten about. You know, it's easy to look at, you know, big things like backs and legs and arms, but, you know, little parts like heels and elbows get forgotten about. So the worst bad thing that can happen as a result of this compression and poor blood flow, the poor blood flow results in ischemia, that's starving for oxygen. Ischemia that goes on for long enough, cells can't live without oxygen, so they die, and that causes necrosis. Necrosis is dead cells. The dead cells break apart and disintegrate because they can't hold themselves together without the oxygen, and you get a decubitus ulcer, also called a decube or a bed sore or a pressure sore. So some general risk factors. Anybody who has a poor circulation or an anemia, they're kind of oxygen starved anyway. So if you add to that already oxygen deficient state, poor circulation in an area, and you're a setup for compression-based ischemia and necrosis. Edema makes the tissue underneath the epidermis, so the dermal layer, it makes it kind of weak and easy to fall apart, so that contributes. Very, very thin people, like elderly or the emaciated person or debilitated person, if you have very little subcutaneous tissue, you don't have much padding in the first place, so it makes this problem worse. Anything, loss of sensation or a CNS deficit, in other words, you either don't feel pain from an area or you're not aware enough to do anything about it, is a risk factor because, why don't we get pressure sores, from sitting around for too long? It's because we move and shift. When skin becomes ischemic, it cries out, so to speak, and it hurts or it becomes uncomfortable and we change our body position. In the person who can't feel that or can't do anything about it, then that problem is going to continue into necrosis. Prolonged static positioning. So anybody who's in one position for a long time is a setup for decubitus ulcers. Mechanical irritation, anything that rubs against the skin can trigger this series of events because it breaks down the dermal layer. Excessive moisture. Moisture on the skin for a long time makes the skin weak. It's more easily broken down, so that leads to this problem. Poor personal hygiene can lead to this one. Inadequate nutrition or hydration. The skin, when you're dehydrated, skin loses its water, so it becomes easier to break down. And then trauma. So anything that's damaging the skin. So there again, tape, clothing, equipment, patients being moved, all those kinds of things. The key to decubitus ulcers is prevention, because once you have one, they are notoriously difficult to heal. They take forever to heal. They have a tendency to get infected over and over and over again. So the best treatment is prevention. First, we get a sort of red and superficial skin breakdown, which many of you who've worked with patients have probably seen that. It's an early warning sign that changes have to be made in how that area of skin is taken care of. And then eventually ulceration follows, and basically that epidermal and dermal layer becomes necrotic and falls off, and you get something that looks like this. So what we're seeing here is the underlying tissue. Here's where the skin necrosed and disintegrated, so we're looking down into the subcutaneous tissue. This is probably muscle right here. So we identify and protect areas of concern in patients, and then we throw as many things at skin care as we can think of. So things like sheepskin helps to cushion. Flotation mattresses are very commonly used in hospitals today, and that's where basically the patient is on a bag of air, so it helps to distribute the weight more evenly, and then moving the patient often. All right, so that's that. Cardiovascular effects. When you first lie down, in other words, when a patient first ends up in the hospital in a hospital bed, the initial effect is actually an increase in venous return. Because instead of the heart having to pump blood up and down like it does when we're standing, when we're lying down, it just has to pump it horizontally, which requires much less effort. So initially we get an increase in stroke volume, an increase in cardiac output, but that causes an increase in blood pressure. So the body wants to lower its blood pressure back down to normal. So there are adaptations that take place. So like the arterioles dilate, so there's less total peripheral resistance. And basically the problem then becomes not that the patient is lying down because their blood pressure is back to normal. But if you've been immobile for a long time, your body isn't used to creating the resistance that is needed to generate a blood pressure when standing. So what happens is When the immobile patient goes to stand up, they get orthostatic hypotension. So when they stand, all the blood falls down basically to their feet, and because their resistance vessels aren't used to contracting against that, it can take weeks for a normal blood pressure control to return. So one of the reasons why we step patients up, to standing and walking around is for this orthostatic hypotension problem. All right. Other issues, immobility means no skeletal muscle pump, so reduced venous return. You don't have the skeletal muscle movement helping to push blood towards the heart. That reduces cardiac output, and it causes blood to pool in the dependent areas. So depending on what the patient position is, it can either be along the back, it can be in the seat or the feet if somebody is sitting. That pooling increases capillary hydrostatic pressure, so you get edema. And then that edema can also reduce arterial flow, so you have kind of this vicious cycle. Once you get a lot of dependent edema, you get stasis, and then clots form, and that can cause ischemia, and then ischemia can lead to problems like decubitus ulcers. So what do we do to prevent that? We keep patients as mobile as they can be. So if you can be up walking around, you should be up walking around a couple of times a day. And if you can't, then you should be sitting if you can sit. As much mobility as we can impart. And then in the at-risk patient, we'll use anti-embolic stockings. These are basically just hose that create pressure around the tissues, and it helps to prevent edema by increasing the pressure on the outside. And then if needed, anticoagulant medicines. So people who are at a big risk for clotting and are immobile are started on heparin or warfarin as prophylaxis against clots. All right. So similar to the cardiovascular system, initially immobility can be a good thing because it reduces the need for oxygen because the body is not having to do as much work. So like one of the early treatments for a possible heart attack is you get them flat and resting to try to drop their oxygen demand to reduce the trouble with the heart there. Supine positioning, which is the most common position for patients hospitalized anyway, has its own limitations. When we lie flat, the contents of our abdomen have a tendency to push up against our diaphragms, so it becomes harder to take a deep breath. When we're standing, which is kind of how the human evolved, the weight is down around our pelvis. It's not pushing up against our diaphragm. So it can limit how deep we can breathe and how effectively we can cough. And that, together with some other things, can start to, reduce how much lung is actually being used. I'm going to talk about that. This effect is amplified by anything that sedates the patient. Most sedatives have some respiratory depression that goes along with them. Or if we have a CNS deficit, patients tend to breathe kind of shallowly when they're in coma because of there's no stimulation for more active breathing. So all of these things together basically create a decline in respiratory efficiency. In other words, your lungs are still working, but they're not working as well because you're not taking as many deep breaths, you're not keeping your airways clear by coughing, and it's harder to take every breath because you've got the weight of the abdominal contents pushing in there. In addition, in the end, what you get is this problem called atelectasis, which is either a reduced aeration or a partial collapse of parts of the lung. So it's not really a collapsed lung. It's a collapsed part of the lung. So if you think of the lung's airways as kind of like a tree, atelectasis is there's a branch that's kind of collapsed in on itself. Instead of having its leaves out, it's all pulled in. So that reduces the area for oxygen to come into the blood, and that can result in oxygenation problems. So we fight this all the time with breathing exercises. The classic one is the IS, the incentive spirometer, which is often a very unpopular order But it's important because it actually prevents this atelectasis from happening. When we're up walking around living our normal lives, we have a breathing pattern that's sort of like this. You know, we take a lot of shallow breaths, but then every once in a while we have what's called a sigh breath. And when you're lying down immobile, you don't do these. You don't do sigh breaths. And what the sigh breaths do is, you know, sigh like as an S-I-G-H, like, huh. But it helps to pop open all of the airways and all of the air spaces in the lungs. So by having this every once in a while, we prevent atelectasis. You put somebody in bed and you give them a few medical problems, they don't do this anymore, and essentially what is lost is this lung volume and this lung volume. So the amount of air in the lungs starts to decrease, and that's atelectasis. So what we do with an incentive spirometer is we ask the patient to take as big a breath in as they can and blow as much of it out as they can. And that serves the same function as a sigh breath, to open up those airways so that atelectasis doesn't occur. All right. In kids, because it's hard to get them to do the incentive spirometer, we used to give them bubbles to blow because it's the same thing. You know, you take a big breath in and you blow as much air as you can out. So it's bubble spirometry. All right. So that's respiratory. In the GI tract, we have the same kind of theme. You know, we really evolved to be up walking around doing things, not laying flat on our backs. So muscle inactivity and that body position of being flat and having the abdominal contents sort of sitting there, it results in slower GI transit, more fluid absorption. In other words, because the contents of the GI tract are taking longer to make their journey, more fluid is absorbed, so the stool gets much harder. Oftentimes in the hospitalized patient, they're not eating well, they're not getting very much fiber, their fluid intake is low, you know, because they don't feel well. So that compounds this problem. And then if they're locked to the bed, in other words, they're not allowed to get up or they can't get up, then they have the problem of defecation is made more difficult by the lying down too because of poor abdominal muscle positioning. You know, the Valsalva maneuver, which empties the rectum, kind of needs an uprightness to it. Otherwise, the forces are going in all the wrong direction. So the bottom line is immobility causes constipation. And that constipation is oftentimes sort of prophylactically treated. In other words, we don't wait for the patient to become constipated. We go ahead and start them on a laxative or a increased fiber and fluid right when their hospital stay begins to try to combat this, because this one's almost inevitable. Anybody who's been on their back for a few days will know that constipation follows. All right. In addition, the inactive patient often has a decreased appetite. You know, if you haven't been doing anything all day except laying in bed watching TV, waiting for your IV antibiotics to get done or whatever, you're not going to feel much like eating. So that, together with the increased metabolic demand of being sick somehow, and patients can get into a negative nitrogen balance, you know, where they're not taking in as much nitrogen as their body is spending, so to speak, to fix whatever is wrong with them. All right. So we have to be sure that their patients are getting adequate protein. That's one of the dietary measures that we take, particularly if they're healing something. You know, if they've got an abdominal wound, you know, from a surgery, or if they've got a broken bone from a trauma or a burn skin, you know, we have to make sure that they're getting enough protein, because it takes protein to rebuild those things and to heal those things. So we have to ensure that they do that. We can do that dietarily or with supplements like Ensure, which is a milk-based product that has a lot of protein in it. But any patient who's immobile for a long time deserves to have a dietitian involved in their care and in their life, because there are lots of things that have to be paid attention to here, and there are lots of choices in modern medicine about how we address those things. All right. In the otherwise normal, conscious person, immobility can result in obesity, because here you have the opposite problem. It's not that you're not hungry, it's that you're not doing enough to burn off the calories that you want to take in. So That's a long-term effect of immobility, can be weight gain and obesity. In the GU tract, again, same pattern. We've all be up walking around. The urinary system doesn't work as well either when you're immobile. You get urinary stasis. This is where the bladder kind of gets more full than it's used to. It doesn't empty as vigorously. And this stasis can predispose to infection or kidney stones or bladder stones. Again, same problem. Voiding is much more difficult when confined to bed. So that too increases urinary stasis and increases the risk for infection. In addition, a lot of immobile patients have urinary catheters in place, and catheters are always a pathway for infection. So just lots of risk factors for infection with immobility in the urinary tract. For kids, we have some other issues in play. Normal growth and development really depends upon motion and being able to move around and play and do different things during the day. So oftentimes, prolonged immobilization in kids results in developmental delay and a delay in normal growth, because the bones require force and stress to grow right. In a little kid who's been immobilized for a long time, there isn't that same force to grow. So they may, let's say they've gone through a congenital heart defect surgery and they, were pretty much immobilized for a year. They will not be as tall as they should, but usually they'll catch up. So once the kid's mobility is restored, they put on the inches, faster, so they catch up. With prolonged immobility, again, you can get some deformities of the bones that in children haven't quite finished growing yet, like the hip, spine, hands, and feet. And then, like I say, developmental delays because they don't have the same level of interaction with the world. All right, so our first question of the day is, I didn't get very many of your answers. Anyway.
Is it too late to log in?
Oh, I'm going to the next question. So yeah, the major problem associated with immobility and the GI tract is which of those things? I only got 6 of you playing along, but there's more than 6 in the room. Are you not being able to get on? Or?
It didn't ask for my name.
It's okay. I moved past that question.
I don't have my thing.
Oh, you don't have your thing with you. There we go. Now we're up to 8. All right, good. And of course, you all got that. So constipation. Immobility leads to immobility of the GI tract. So constipation. All right. What is the major factor predisposing to pulmonary infection in the immobilized patient? There we go. Now we're getting everybody playing along. All right, good. So it is B, the stasis of secretions in the lungs. And the reason for that is lack of deep breathing. When you're on your back, it's hard to breathe deeply, and when you're sick, you have a tendency to not breathe deeply anyway. And what happens is, as the air spaces don't get opened up in these side breaths, secretions build up in there. So basically, an atelectasis is sort of like, if this is a lung here, and you've got your pulmonary branches that come out like this. And atelectasis is like one wedge of the lung that's sort of blocked by secretions. Now, you can clear that secretion, but you have to take a big breath to do so, because you've got to pull open this fluid-filled space to get air moving through there and get that fluid mobilized. All right. And that's it for immobility. Probably lots of things that many of you have heard before in some of your other classes. But all right. So onward to stress, which none of you know anything about, I'm sure. All right. So stress is not just the emotional version. In other words, there is both physical stress and mental stress. And the reality is both influence the body in kind of the same way. So that's, one of the take-home messages of this influence of stress on disease is that one. So the stress response occurs anytime there's a challenge to either the mind or the body in terms of something in the environment has changed, and that change is resulting in something negative. And it turns out that regardless of the cause of the stress, its effects are pretty much the same, and they're the same across people, and it involves most of the different organ systems of the body. So your book talks about it as the general adaptation syndrome, the GAS, but I've always heard it called the fight or flight response. And it can be triggered by any number of things. So psychological, we've certainly all experienced that. Physical stressors would be things like disease. Any kind of disease stresses the body, and that triggers this same stress response. So that could be infection, trauma, autoimmune disease. Environmental, things like hot and cold, very hot days create a stress response in us, particularly if we're out in it. Very cold, it's the same thing. Now, the stressors vary widely. In other words, some people, very laid back, they don't get worked up about anything. And then there are some people for whom the slightest little thing, elicits a stress response. So what a stressor is varies a great deal across people, but the response to an identified stress or a present stress is pretty much the same across all people. So some people have a quicker stress response, some people have a slower one, but the stress response itself is the same across everybody. So, and just again, not all stress is psychological. It can be from any stressor on the body. So cold, heat, pain, infection, cancer, autoimmune disease, any of those things. All right. So usually, part of the stress response or is to bring about a positive change. In other words, to reduce or eliminate whatever that initial challenging factor was. Now, if a stressor is persistent, in other words, it's not something the body can deal with, or it's not something the person can change, then we have a long-term stressor which can result in some maladaptive changes. In other words, changes that make things worse, or at very least don't make things better. So we can look at the effects of the stress response sort of in two categories. There's the sympathetic nervous system driven responses, and then there's the hormonal system responses, which includes not just the adrenal gland, well, it includes the adrenal gland, but not just epinephrine and adrenaline, but also things like cortisol, as we'll see here in a moment. So the sympathetic nervous system works with the adrenal medulla. That's the inside, and it produces norepinephrine and epinephrine. And then also the adrenal cortex produces some other hormones like cortisol and some other steroids, which then go on to have multiple effects. So your book kind of presents a lot of information in this one diagram, but it is worth looking at. Even though it looks all cluttered and nasty, there's a lot of good information here. So, here's our stressor. This can be anything. This can be psychological, physical, or physiological. So The CNS is activated by that, either through perception or thought, or from underneath, so to speak, with visceral sensation and things like that. So we get a limbic system response and a cerebral cortex response. The limbic system is our emotional center. So when it's triggered, if you've ever been in a suddenly stressful environment, you can feel an emotional change. That's your limbic system. And then the cerebral cortex is going to immediately be trying to solve the problem or fix the situation. So both of those are going on. But then down underneath that in the physiological, the stressor through the CNS activates the hypothalamus. The hypothalamus activates the sympathetic nervous system, which releases norepinephrine at its nerve endings. You remember, that causes vasoconstriction, an increase in heart rate, an increase in contractility, bronchodilation. Some of those things are down here. So these are the effects of the sympathetic nervous system. And then the sympathetic nervous system also triggers the adrenal medulla to release epi and norepi, which have many of the same effects as the sympathetic nervous system neurons do, but they're much more widespread. So some of those things, vasoconstriction here, elevation in blood pressure, pallor of the skin. Vasoconstriction means less blood flowing through the skin, so your skin becomes less pink or less red, and we see that as pallor or whiteness. Bronchodilation, the airways dilate to increase oxygen flowing in. Epinephrine has direct effects on glucose levels. It increases blood glucose. In the fight or flight response, this sort of makes sense. If you're suddenly faced with a mountain lion, well, your cells are going to want to have plenty of fuel around to either fight or flee. So that's a direct effect, is blood glucose levels go up. The heart beats faster and stronger. And then in skeletal muscle, there's vasodilation. So there's two places in the body where sympathetic nervous system stimulation causes vasodilation instead of vasoconstriction. That's skeletal muscle, so you can fight or run from the mountain lion. And the other place is in the brain, and that's so you can outthink the mountain lion. So there's two spots where blood flow actually goes up. So in a sense, the sympathetic nervous system steals blood from the skin in favor of the skeletal muscle, and you could add brain over here too. All right, so those are all effects of the sympathetic nervous system part. But then if we go all the way back up to the top, the hypothalamus also triggers, this is the hormonal response over here. The posterior pituitary releases ADH, antidiuretic hormone, helps us hold on to water, which is a good thing. If we're being stressed, we want to make sure that we have plenty of fluid in our bodies because we may not have access to fluid, while we're fighting the mountain lion, so to speak. So that causes us to hold on to water. It also, incidentally, triggers the thirst mechanism. And then from the hypothalamus through the pituitary, we have cortisol is released. Cortisol is a glucocorticoid, which we talked about when we talked about inflammation and the treatments of it. And, you might ask, well, why is an anti-immune system chemical released as part of the stress response? The idea evolutionarily here is that if you're in a fight or flee scenario, you should be more damage-proof than you are inflamed. In other words, you shouldn't have swelling and itching and stuff like that if you have a much larger problem of a mountain lion trying to eat you. So cortisol turns the immune system down in favor of a more robust response and a less sensitive body, essentially, so that we can take more damage and not be crippled as much by it. But cortisol does lots of things. So it, too, increases blood glucose levels. It also increases amino acid levels. Again, provide the fight or flight nutrients, provide the skeletal muscle with plenty of nutrients so that it can continue to fight if need be. Healing is delayed. If we're fighting or fleeing, we don't need to be spending money on patching up or spending energy patching up our wounds. So cortisol sort of puts that off until later. Cortisol directly affects the central nervous system. Anybody who's been on steroid medication might notice that your mood is different. You know, you're more aggressive, you're more easily irritated and things like that. You really see it in kids who end up on steroids a lot for like asthma. But you'll see profound personality changes, and that's cortisol's effect. It stabilizes the cardiovascular system, cortisol does. So essentially it helps to support things like blood pressure, which are, of course, important for blood flow. It increases gastric secretion, so it can lead to ulcers, cortisol can. Decreased inflammatory response, allergic response, and immune response. So essentially cortisol turns off the long-term concerns, you know, like illness, disease, and wounds, in favor of short-term concerns like fighting and fleeing. So it's many of these effects that cause the long-term physical effects of psychological stress. You know, because the reality is, you know, your big exam that's coming up isn't really like a mountain lion. It's not actually going to hurt you, but your body responds like it's a thing that can hurt you. So, you know, you can end up with ulcers from too much gastric secretion, immune deficiency. You know, you get sick more when you're stressed, and that's because of these cortisol effects. And the thing with a final exam, let's say, is instead of a mountain lion where it's going to be a short episode, you know, the final exam stress can go on for weeks. So you can end up having, you know, more susceptibility to illness and things like that. So lots of stuff on these. So potential complications of stress, you know, here's your short list. Hypertension, high blood pressure. Why? Sympathetic nervous system overdrive, as well as cortisol supporting that blood pressure, so it amplifies the norepinephrine response. Tension headaches, that's from hypertension as well as a generalized increase in alertness. Basically, muscle tone goes up, so all the muscles are a little more tense than usual. Insomnia, you know, if you've got a fight or flight response going, the last thing you want to do is be tired and go to sleep. So the stress response has a tendency to keep people awake. You know, you can imagine, to deal with whatever is the stressor. You know, why go to sleep when you can fix what the problem is? Diabetes, and that's from this area and this area right here. Both cortisol and the sympathetic nervous system increase blood glucose levels. And if you already have a sort of weak insulin system, it can push you right over into a diabetes crisis. Increased risk of infection, that's because the immune response is delayed because of the cortisol. Heart failure, let's say your heart isn't perfectly healthy anyway. You know, you've had a few minor heart attacks and you know, your exercise tolerance is low. Well, a prolonged period of sympathetic nervous system drive can push your heart over into failure because now it's trying to answer the fight or flight call and beat harder and faster and stronger and generate more pressure, but it just doesn't have the capability to anymore. So it can flip you over into heart failure. Ulcers from the gastric secretion increase, and then in addition to insomnia, fatigue. Now, fatigue is not a direct effect of the stress response. That wouldn't make any sense. The last thing we want to do is be tired when the mountain lion's coming at us. But over time, these things wear the body out. So, you know, when you get to that worn out phase, fatigue sets in, and it can be rather, you know, extreme and sudden onset. You know, if any of you have, like, done an all-nighter and spent the whole night studying after the test, you just, like, collapse in a heap. And that's because you've burnt out all of your reserves, basically, using that stress response to power it. All right, so that was a lot. That was the real meat of this whole chapter, really, is in that one diagram. But, you know, the title of the chapter is how the influence of stress on disease. So how do stress and disease interact? Disease can cause stress, but stress can also get in the way of disease resolving or the patient dealing with disease. So usually stress exacerbates any underlying disease state. So, for example, asthma, you may be fine, but then with the stress response, it may flip you over into an asthma exacerbation. Or, if you have an autoimmune disease, let's say, that stress response will, because it's stressing your body, in other words, it's increasing the metabolism, it's asking for more out of the system that's there, it can trigger things like cold sores, it can trigger increases in blood pressure and heart rate. These can then trigger cardiovascular problems if you have a non-normal heart, for example. So typically, stress makes diseases worse. All right. So there is stress plays a role in a number of chronic diseases, not only in exacerbating, but also in perpetuating or even causing. So the list right from your book is, these are stress-related disorders. So if you are under stress for a long time, these are these maladaptive syndromes. So things like, there's a whole long list that I'm not going to go into all those, but stress is related to lots of different diseases in lots of different ways. All right. Probably the most problematic form of stress is the psychological version, because oftentimes it creates a vicious cycle. Essentially, if you're stressed about something you can't change, then how is that stressor ever going to disappear? So one of the reasons that we teach people things like adaptation mechanisms or acceptance mechanisms is to try to break that cycle of stress. You can't stay stressed out about a thing you can't change. You either have to let it go, you have to change how you think about it, you have to do something to break that cycle of continual challenging of the body or stressing the body. All right. So some of the complications of the stress response, and these really more relate to physical stresses like disease or trauma, things that have challenged the body physiologically. We can see these complications. So acute renal failure. If we go back to our big nasty diagram here, vasoconstriction is seen all over the body, but one of the places that it's seen most profoundly is right here at the kidneys. So when the sympathetic nervous system is, when you're in that adrenaline rush or when it's pumping out norepinephrine and epinephrine, the kidney, the GFR goes down. In other words, the glomerular filtration rate. And that's fine in the short term, because you don't really need to be making urine if you're fighting or fleeing. But if that stays true for a long time, the kidney is actually very sensitive to reductions in blood flow. So continued vasoconstriction can result in the renal arterial supply being inadequate, and basically the kidney starves for oxygen. It becomes ischemic, and its first response to that is going to be acute renal failure. So here again, you're not going to get this from stressing out about a final exam. This is like, your body is fighting off a septic shock, for example. So, you have massive vasoconstriction to try to keep your blood pressure up, and the kidney basically gets starved. So what we do to combat this is anybody who's in that kind of intense physiological stress, we make sure they get plenty of fluids, because plenty of fluids should keep the blood and urine flowing in the kidney. And then in extreme cases, we're fighting shock, for example, profound low blood pressure, and we're giving epinephrine like on a drip to try to keep their blood pressure up. We often will give a little bit of dopamine, because dopamine dilates the renal arteries. So we can sort of trick the body into letting more blood into the kidneys in these very sick patients. Yeah?
Wouldn't you have vasoconstriction and the hypertension is going to make the blood go into the kidney with more pressure, but the kidney's getting less blood, so are you going to get like a blowout or something?
No. The blood pressure is tricky to think about sometimes, because you've got two aspects of it. You've got blood pressure and blood flow, right?
Yeah.
This is the more important thing. because it's flow that brings nutrients in and gets waste products away.
Okay.
But in order to make flow, you need blood pressure. So what the body tries to do is keep a solid blood pressure that then it can direct into whatever parts of the body need it. So like you might have kidney here, brain, muscle, heart, let's say. So in the very sick patient who has a low blood pressure, we want to get their blood pressure up to save these organs first, because they're going to be most easily damaged. So what ends up happening is less and less of this blood pressure becomes flow to the kidney while we're trying to save the heart or brain. Does that kind of make sense? Yeah. Good question. Blood pressure and blood flow are tricky. It's ICU level medicine, so there's a lot of stuff going on in there. Other complications, similar to renal failure, when there's massive vasoconstriction in play to try to keep as the body tries to keep its blood pressure up, one of the other places besides the kidney that starves is the stomach or the GI tract. Because in that fight or flight response, these guys are left out. The brain, muscle, and heart, they get extra blood flow from this high blood pressure. But the kidney gets less, and the GI tract gets less. So if it's extreme enough, the GI tract will basically start starving for oxygen, and one of the results of these is what they call stress ulcers. And these are ulcers usually in the stomach or duodenum that are created by a reduction in blood flow to those areas. Because remember, the GI tract is on the opposite side. It's parasympathetic, so it's the rest and digest system. So when the fight or flight system is on, the stress response, the rest and digest gets left out. So they end up getting starved for oxygen. So these stress ulcers can happen really fast. Like, say somebody had a hypotensive episode for even an hour, and they got their blood pressure up, but even that short amount of time in that intense stress can cause breakdown of the stomach mucosa. All right, talked about that already. So when we have a patient who is in this heavy-duty physiologic stress response, we try to take care of their gastric mucosa basically. So we may give them Pepsid or Prevacid to block acid secretion in an effort to try to prevent these stress ulcers from occurring. They're actually very common complications of an ICU stay. Say you had shock for whatever reason from trauma or infection, and you spent some time in the ICU on some drips to keep your blood pressure up. Many of those people will have stress ulcers, and not all of them come to medical attention. But days later or weeks later, they may complain of lasting abdominal pain, and it's going to be stress ulcers that are the culprit there. All right. So immune system function is depressed by the cortisol branch of the hormonal branch of the stress response. So you see opportunistic infection, like we talked about cold sores, for example. But basically, a prolonged physiological or psychological stress makes you a little immune deficient. So it means you're going to be more susceptible to more different kinds of infection. And you may not be able to identify that you have an infection as early because the stress response turns off inflammation. How do we know that we have an infection? Well, if it's skin, for example, redness, warmth, swelling, and pain, right? That's inflammation. Well, if your adrenal glands are pumping out cortisol, you're not going to see redness, swelling, warmth, and pain because that part has been turned off or turned down. So it means that an infection can be much larger before it comes to anybody's attention because the immune response is being squashed. Long term, you get effects on the lymphoid tissues. It actually starts to shrink down, a decrease in circulating leukocytes. So it basically is all the same thing. That cortisol is ratcheting down the immune system trading short-term gains for long-term problems, essentially. All right. Cortisol, in addition to reducing the immune system, also delays healing. You know, there again, if we're in fighting or fleeing, we're not trying to heal our wounds. We're trying to get away from having more of them. So they reduce protein synthesis and tissue regeneration. So essentially, the body is catabolic. Catabolic just means that it's using itself as nutrients instead of building itself. So anabolic is building, catabolic is breaking down. And that, so reduced healing and vasoconstriction together mean that it's very difficult for wounds to heal, and the risk for infection at wound sites is also very high. So when we have a patient who has a big wound, we try to reduce stressors. You know, it's one of the reasons why we have people rest, and we have them drink plenty of fluids, and we have them try to be as calm and normal as they can, is because that stress response actually gets in the way of healing. So, you know, out there in the world of animals, you know, when this would play along is, you know, after an animal's been in a fight, let's say, at some point it goes and it seeks shelter and security so that the stress response will wane away, and then the wound healing can take place after the cause of the injury has been dealt with. All right. So coping skills. You know, physiological stressors in some ways are way easier than the psychological version because many times we can directly affect those. You know, if your blood pressure is low, you know, we can get your blood pressure up. If you've got an infection, we can treat your infection. It's the psychological stressors that are more difficult to treat because often, you know, the medical community has absolutely no say in the psychological stressors in your life. You know, they can't change or alter anything there. Now, thankfully, the psychological stressor does not cause the profound physiologic impact, you know, like acute renal failure and stress ulcers and things like that. Instead, it's more of a lower level stress response, but it goes on for much longer. So it can cumulatively have some of the same effects, you know, like immune suppression, diabetes with the glucose metabolism from cortisol. So one of the things, you know, that we do with our caseworkers and our psychiatrists and psychologists in patients dealing with stress is to try to teach them new ways to think about their stressors, new approaches to solving those problems, you know, plugging them into various social programs and things like that. So things that promote problems with stress are fatigue, age, inadequate nutrition, lack of knowledge, community and emotional support is a big deal. You know, when people are sort of all alone, they have more stress and less ability to deal with it because they have no help, they have no advice, they don't even really have anybody to talk to. So we try to plug patients into various social networks and things like that to get them back up and running. So what do you do? Coping with stress, adequate rest, and a healthy diet never hurts. As well, I would add exercise. Oh, it's already on here. A regular to moderate exercise program. You know, psychological stress is creating physiologic changes, but those physiologic changes can't do anything about the psychological stressor. So it's sort of a broken feedback loop. You know, the stress is causing changes, but the changes are going over here instead of changing the stress. So what exercise does is it gives the changes something to do. So we would call this exercise. Exercise turns that increased blood pressure, increased heart rate, increased blood glucose level back into something productive. You know, so it basically helps to break that cycle by using up some of those physiological changes. So exercise is not just good for your long-term health, it's also good for your, you know, short-term well-being, particularly if you're in a time of stress. You know, and a lot of times one of the first things that goes is people's exercise regimen. But the reality is that's when you need it most, is when you're dealing with a lot of stressors to burn up some of that physiologic change that's coming from the old noodle in the head. All right. Other mechanisms, distraction, and we use this in kids a lot, but get somebody's mind off their problems for a while, and the physiologic changes from the psychological stressors start to go away. Now, when you come back to it, they're going to come back. But at least you've given your body a break, from the sympathetic nervous drive and a break from the cortisol. Active techniques to reduce concern, things like relaxation therapy, imagery, biofeedback. Your book talks about music and art therapy. If none of those behavioral changes work, then you go to anti-anxiety medications, or as Carolyn said, the kind that comes in a bottle marked beer. But you have to be really careful with using anti-anxiety medicines in the stressed out person, because they're a setup for addiction. Here they have this problem that they can't solve, and you give them a medicine that makes it seem to go away. And then when that medicine wears off, it comes back, and now you're into an addiction cycle very quickly. So in some ways, you should never just use medicines. You have to be helping the patient fix whatever the problem was that led to the stress in the first place. So, medications do this, they don't do this. So you have to be very careful with those things. All right. And then a methodical approach to solving the problem. So life counselors, essentially. Sometimes what that caseworker in the hospital is doing is just helping that person solve the problem. All right, so severe prolonged stress may cause acute renal failure or stress ulcers to develop. Why? All right, there's everybody, I think. So the correct answer there is D. The stress response causes vasoconstriction everywhere except the skeletal muscle and the brain. So in the kidney and the stomach, for example, are not included in that list. So prolonged vasoconstriction reduces blood flow to those areas, and that can result in starving for oxygen, which is ischemia. That ischemia can then lead to necrosis, which would be a stomach ulcer. And in acute renal failure, ischemia just makes the kidney not work as well. Essentially, it starts dumping fluid and not doing its job. All right. So the basic physiologic response to stress is the same in everybody. Nice, simple question. True or false? All right, that's everybody's committed. So that's true. So the difference between people is what is a stressor. There's a huge variation there. But once a stressor is present and has triggered the stress response is pretty much the same in all individuals. So the big difference there is psychological. The physiologic stresses we're all going to share pretty much in common. All of us will respond to a low blood pressure in pretty much the same way. So it's the identification of a stressor that's different, but the response is always the same. And that's it.